HF trial. Here are my disclosures, the most important of which is I'm the principal investigator of the Reduce LAP HF2 trial, atrial shunt in HFpEF. So there are quite a few atrial shunt devices and procedures out there right now, as you can see here, and there are many different shapes, sizes. Some are devices, some are deviceless, but suffice it to say, this is a burgeoning field. Now, what's interesting is that not all of them are studying all EFs. In fact, most of them are been focused on heart failure with preserved ejection fraction, as shown here. And so when we see this trial and we see the results, we're asking ourselves two key questions. Are atrial shunts harmful in all patients with HFpEF? And why did the patients with HFrEF benefit from the device? So let's go back to Reduce LAP HF2, which is the only other randomized pivotal trial in the shunt space completed to date. This was the Corvia atrial shunt device in HFpEF and heart failure with mildly reduced EF. 626 patients randomized 1-to-1, exercise right heart cath in all, to confirm that the peak exercise wedge pressure was greater than or equal to 25. So that was a key difference between Reduce LAP and Relieve HF. Reduce LAP required that exercise invasive hemodynamics. The primary outcome was similar, and the overall trial was similarly neutral, with a win ratio of 1. But we conducted a pre-specified and post-hoc subgroup analyses and found this group that had a peak PVR, a peak exercise PVR of less than 1.74 and no pacemaker or ICD. And they did at 12 months have a beneficial response with a win ratio of 1.4, reduced heart failure events, and improved KCCQ. And as we extend that to 24 months, and we now have 36-month data, it's pretty much the same. The responders on the left have a win ratio of 1.4, a 50% reduction in heart failure events. The non-responders on the right have a win ratio of 0.7 and a twofold increase in heart failure events. So the big question is, are the Relieve HF HFpEF group, are they more like Reduce LAP responders or non-responders? So we don't have the HFpEF versus HFrEF data in the pivotal trial, but we have the roll-in cohort was recently published of Relieve HF, and we assume that the characteristics are going to be very similar to those who are randomized in Relieve HF. And I want to show you here and point out, if you look at this, if you look at AFib, if you look at pacemaker ICD, if you look at NYHA class, if you look at NT-proBNP, what we're seeing is that the Relieve HF HFpEF group is a sicker version of the non-responders. They're similar to the non-responders, but a bit sicker. Let's look at their hemodynamics next. So if we look at their hemodynamics, the TAPSE is only 16, so very, very sick right ventricles. RA pressure is similar, mean pH similar, wedge pressure similar, but look at the cardiac index, 2.3. These were very, very sick HFpEF patients, and the PVR was 2.5. In Reduce LAP HF2, if your resting PVR was greater than 2, you had a 10-fold increased risk of a high peak exercise PVR. So I believe that the Relieve HF patients in the HFpEF group were very similar to the non-responders in Reduce LAP HF2. And so I think these two are very similar. The curves look similar, and I think these are concordant results. Now, why did patients with HFrEF benefit? Well, it could be that they're better able to handle the LV unloading due to large LV size. Maybe they had less sick RA and RV. Maybe they had a greater discordance between the left-sided heart failure and right-sided heart failure. And then the effects of GDMT over time may prevent the progression or even reverse RV dysfunction. Now, when we did the echo analysis, I don't have time to go through this whole slide, but just look at the right. What we did was a longitudinal echocardiographic analysis of the responders versus non-responders. The responders in the Reduce LAP HF2 trial, they had more left heart unloading, better improvement in LA function, less RV enlargement, and better RV systolic function in response to the shunt. And this allowed for increased delivery of blood through the lungs, and they benefit. What happens in the non-responders is the blood shunts and just sits in the right ventricle and doesn't go anywhere. And that's bad for patients, and that's why I think we saw that the non-responders didn't do well in the Reduce LAP HF2 trial, and I think that's why the HFpEF group didn't do well in this trial as well. And the HFrEF patients, however, did do well, so there's something there. Maybe they can tolerate this reduction in LV size. Maybe their RV can handle it. So, are atrial shunts harmful in all patients with HFpEF? No. Why did patients with HFrEF benefit? Unclear. There's many remaining questions that we still have to answer, and I look forward to future publications. The take-home points are that HFpEF is heterogeneous, one size doesn't fit all, And the Relieve-HF HFpEF group are sicker patients that are like the REDUCE-2 non-responders. I believe that the Relieve-HF validates REDUCE-LAP HF2 results, and both trials still provide strong rationale for the current trials in HFpEF with shunts that are ongoing. So I'm really excited about the HFrEF results, and we look forward to them being further analyzed mechanistically. Thank you very much.